Good afternoon, and welcome to the 5th Annual AFC Summit, proudly hosted by Nonotuck Resource Associates and the statewide AFC Roundtables. This year marks the second year of the AFC Summit having gone virtual through the development of this webinar series. Although virtual, the mission of the AFC Summit remains to provide an opportunity for AFC provider agencies to learn from one another, to share information and resources through networking, and to continue the ongoing dialogue between organizations through our statewide AFC Roundtable groups. These groups will return to a regular meeting schedule beginning July 2021 in a virtual format. Today, you will have two moderators, myself, Deb Schneer, and Carrie Parody, who will assist with Q&A. A few brief instructions for participants. All participants have entered today's webinar muted and with their cameras turned off. We ask, out of respect for your presenters, that you do not turn your cameras on or unmute unless directed by the moderators during the Q&A. Please submit your questions to the presenters through the chat located on your Zoom toolbar, and presenters will respond to your questions periodically throughout their presentation. Without further delay, we'd like to introduce today's presenters, Gregory Stelmack, President and Clinical Director of VRNS, and Patricia Phillips, Community Development Coordinator for VRNS. Welcome to you both.
Thank you very much. And let me take a moment here to share my screen. And first, I want to thank the AFC Summit for allowing us to be a part of the one of the presentations for this great summit. And welcome to VRNS, Home Healthcare and Educational Services to Promote Optimal Functioning for AFC Individuals and Caregivers. This is presented by myself, Greg Stelmack, Clinical Director and President. And also I welcome Patricia Phillips. She's an occupational therapy assistant, as well as a community development coordinator for us. So first, a little bit about myself so you know who I am and where I am coming from. By trade, I am an occupational therapist. Whatever I do, whether it's running the business, being an occupational therapist, or even through everyday life, I always have that occupational therapy clinical hat on. I am the president of VRNS, which includes Visiting Rehab and Nursing Services, which provides skilled nursing, PT, OT, and speech therapy services through insurance like Medicare, MassHealth, and other payer sources. Also, Home Again Healthcare, which we are a provider of skilled nursing, PT, OT, and speech therapy services through the ABI and MFP waiver programs. Visiting Rehab Services, which provides outpatient physical therapy, occupational therapy, and speech therapy at adult day health programs. VRNS SME, which provides durable and specialty medical equipment through the ABI and MFP waiver programs, as well as private pay. And VRNS EDU, which provides live webinars, on-demand clinical series, and various clinical programming, which all of these you'll learn a little bit more about. I have extensive clinical and executive experience working with various populations, but really specifically focusing on individuals with developmental disabilities, acquired and traumatic brain injuries, and also the geriatric population. And most of my both executive and clinical career has been concentrated in working with individuals in the community. Instead of going through a laundry list of objectives through the presentation or for the presentation, one kind of overarching goal that I would like for you to achieve is at the conclusion of this presentation, you will be able to identify clinical and education services that will help community-based individuals function at their optimal level. And first, I want to go back a little to 2008 and just sit back for a second and think about what was going on in the world, in our lives, in our personal lives, And at that time, we were in the middle of a financial and housing crisis. The number one television show was American Idol. Gas was about $3.40 a gallon. And we just elected a new president, Barack Obama, and which was important for many different reasons. But one of them related to healthcare was shortly thereafter was the development and then passed into law was what's commonly known as Obamacare. And one of the reasons I mentioned that is it changed a little bit of our thought process when it came to healthcare. In this word prevention now popped into the healthcare arena. So myself and one other partner of mine who's also an occupational therapist, we had this vision. And our vision was to provide community-based PT and OT services to promote optimal functioning for those individuals. And there were many different barriers to that in terms of funding sources and being able to justify our services, but that was our vision. And we were looking and putting this together, and we were able to accomplish it. And what we did is we changed approaches in the treatment approach to physical therapy, to occupational therapy, to community-based providers. And we took this model, and you think about before Obamacare, before thinking back 10, 12 plus years ago, that what happened when somebody needed services, an event would have to happen. Sometimes they would have to go to the hospital in order to really qualify for services. And that model was more of a remediate or a restoration model. And we shifted that. We shifted that to more of a modification, or how do we prevent somebody from declining? So from a PTOT standpoint, we really looked at skilled preventative evaluation and treatment. And one of the key features to that, to justifying our services, demonstrating value, and frankly, increasing quality of life and optimal functioning, was the introduction of evidence-based evaluation tools. And two of those are, one is the TUG, which is the timed up and go, and one is the functional reach. And during my presentations, not only are we talking about topics, we have objectives, but I try and also provide some resources that and takeaways from the presentation, not only about the services, about the topic, but something that you can incorporate into practice, work with, whether it's your caregivers or your actual family members. And this is one of them, the timed up and go. We'll talk a little bit more as we talk about fall risk, and this will be available for you as a handout. But it's very important to think about, and it's one of the evidence-based tools that is now very common in practice. And not only can a nurse use this, a physical and occupational therapist or a clinician, but even a more family member, caregiver that doesn't have that clinical background can use this tool to identify or see, are there changes in individuals or patients for their risk of falls. And throughout this change in the treatment and the use of evidence-based evaluation tools, we created what is still known, and we still have this company and utilize these services, Visiting Rehab Services, which provides physical, at the time, just physical and occupational therapy to individuals in the community to promote optimal functioning and prevent hospitalizations. So instead of an event or a fall or decline happening, we were looking and we changed that focus to, how can we prevent that hospitalization? How can we help an individual in the community? Maybe they're struggling just a little with their ambulation or gait or transfers or ADLs, whatever the reason is. And how can we get them to their optimal level? So maybe they're slightly more independent, slightly safer, but overall increased quality of life and optimal functioning. And really, our primary referral relationships that we worked with were community-based providers like the individuals through the AFC program. So now we move to 2015. And on the screen here, it was kind of fun when I went back and kind of looked at pop culture and what was going on in those years. As it related to COVID, it does seem like 2008 and 2015 was about 300 years ago. But if you can remember, this dress kind of took over the internet, and the debate was, is it black and blue or white and gold? So I just kind of thought that was funny going back and looking at 2015. And I kind of go in order here because we have this model of providing PT and OT to community-based individuals. And from 2008 to 2015, from a business standpoint, from an ability to provide services, from an ability to increase the quality of life of so many individuals, seniors, individuals with head injuries, with developmental disabilities, we were missing one piece to that pie. And that piece was the ability to provide nursing services under that same model. And so at that time in 2015, we took our resources and we actually acquired a small VNA, a small home healthcare agency, and now created Visiting Rehab and Nursing Services. So now we have the same model, but we could now provide nursing, PT, OT, and also speech therapy services to individuals in the community, still promoting optimal functioning and preventing hospitalizations. And we continued to use those evidence-based tools to promote that functioning and justify our services. And as an example, one of those tools from a nursing standpoint that we use is called the Braden scale. And we use that for both individuals and patients being discharged out of skilled nursing facilities and hospitals. We do work with those, but our focus is really those community-based individuals. And the Braden scale, once again, as a resource for you, that this looks at the risk for skin breakdown for our individuals or patients in the community. And it helps create a treatment plan. So once again, we might not have somebody that has a skin breakdown or a skin tear or a wound, or decubiti are many terms. But we can look both from a nursing and a therapy standpoint and evaluate and provide recommendations based on an evidence-based tool from a nursing perspective. So as we continued to progress as a company, we looked at all of our programming, and we once again became, or we wanted to enhance our community-based programming with the model and the vision of that optimal functioning for community-based individuals. And we became a provider for the ABI and MFP waiver programs. And the ABI is the Acquired Brain Injury Waiver Program. And the MFP it was once called Money Follows the Person. It is now called the Moving Forward Plan. And these programs are primarily focused to move individuals out of skilled nursing facilities and have them live in the community, whether that be in an AFC type of setting, whether that be on their own, whether that be with a family member, or also in a congregate or group home setting. And under these programs, products and services that are not covered by insurance are covered under this program. So we think about many individuals that are in a skilled nursing facility. And why can't they be in the community? One, they either don't have the resources to assist them, both physically to help them or financially to pay for these services. And now these programs cover those products and services where the gap between what insurance covers, because in the community, they don't cover that ongoing service. And now the waiver program covers that service. How we are involved in those services are we provide through both the ABI, for the ABI, we provide ongoing PT, OT, and speech therapy services. And through the MFP, we provide ongoing nursing, PT, OT, and speech therapy services. And the great thing about this, with approval from a service coordinator or case manager, this is an ongoing benefit or service. These individuals can receive these ongoing nursing, PT, OT, and speech therapy services essentially for the rest of their lives. And these services fit naturally into our model, our vision of providing optimal functioning. And on average, nursing through the MFP covers once a week, and it's a wellness program. So you can now go in and just check, how's their heart rate? How is their blood pressure? How is an individual's blood pressure? Are they at risk for wounds because they're sitting in their wheelchair all day? And PT, OT, and speech, on average, we see an individual 2 times a week for each discipline, if approved, and we get them to their optimal level. And the best thing about this is we can now stay in there to keep them at their optimal level. Where in a traditional setting, we have to educate, and it's a big piece of what we do, educate a caregiver or family member involved. And at the bottom of the slide is a link for a YouTube video that is put out by MRC, the Mass Rehab Commission. That is a great video that goes over a little bit about these services. but also talks about contact information if you think or might have a family member or a client or an individual that might qualify for these services. The generic qualification for these services is you had to have been in a skilled nursing facility within the last 5 years for greater than 90 days. And there's a certain couple of diagnoses that somebody might have to have in order to qualify for these services. Do note too that following the presentation, our friends at Nonotuck will be providing handouts, so you will have these resources and the link to this webinar. And also, I do remind everybody that throughout this presentation, please, if you have any questions at any time, to ask them in the chat. So once again, we're back in 2015, 2016, and as a company, we not only are we providing nursing, physical therapy, occupational therapy, and speech therapy services with the model of the optimal functioning in the home for community-based individuals. But what we were finding was that whether it be a family member or a caregiver, these caregivers did not have clinical backgrounds. And even the uniqueness of this model and the uniqueness of the thought process of prevention and not waiting till something has to happen to put interventions in place, we wanted to educate both not only just our staff that we do on orientation and continuously, but we wanted to educate the providers that we work with. So whether that be a case manager, a nurse, a DDS service coordinator, a group home, a geriatric care manager, but we also wanted to get this information to caregivers, to direct care staff, to the people that work with the type of client in the community every day. They are the first line of eyes and ears about what's going on and can identify right away if there is an issue that we can intervene from a prevention standpoint. So we put together numerous live presentations, and they were on dysphagia and aspiration prevention, fall prevention, skin breakdown prevention, and safe individual or patient handling, like how to best transfer somebody, how to best walk or ambulate somebody. And even within that one, how to put on a gait belt. So some real, just great content. And this became wildly popular, where we were doing a little tour around Eastern Massachusetts, primarily in MRC and DDS offices, that we would provide these presentations every quarter on a different topic. And it went very, very well. And these are to work with our providers, and so people are aware that prevention can happen and that there's services out there, and that we can provide you with some general techniques and strategies that you can currently use with your patients, individuals, or clients. And then, of course, 2020 hit, and we all know what happened in 2020. And COVID happened in 2020. So we all remember just over a year ago how things changed in our personal lives and in our professional lives. And as a company, and most companies, from a business standpoint and a providing services standpoint, the word of the year was pivot. And we had to pivot from providing these traditional services, and how can we still reach our individuals and patients, but still provide the services that they need. So as a company for visiting rehab and nursing services, so the company where we provide the nursing, the PT, the OT, and speech therapy, we offered a telehealth version. So for nursing, for PT, for OT, for speech therapy, if it was clinically appropriate, if the individual or family had the physical capabilities, not only are we still offering those in-person visits, but we were offering a telehealth version. So we could still be in front of our patients and our individuals as needed. And telehealth, as we know, even today for these presentations, it's not quite the same as even doing our presentation in front of you today. But to the best of our abilities, we were still able to provide those services and be able to continue to be with our individuals. Also, as a company, we had to do a mass distribution of PPE. And just going back to the tele everything, as I call it, even to this day, as we move into our new norm, we still offer that telehealth visit if it's clinically necessary. Or if for some reason there's a family member, an individual that does become positive, and to keep both them and others safe. And from a PPE perspective, right away, we, and to this day, continue to follow the DPH, the Department of Public Health regulations. And even though even last week on May 13th, they were relaxed, we still currently have our staff wear at least a KN95 mask, they wear goggles, and then gloves and a gown if necessary during those in-person visits. We also, and even to this day, we have our staff tested for COVID. If they have not been fully vaccinated meaning that they have had either the Pfizer, Moderna twice in a status post 2 weeks, or the Johnson & Johnson in status post 2 weeks. But we still maintain those testing guidelines for COVID-19 because we do a lot of work in congregate housing, which includes assisted livings, because that model fits perfectly also in assisted livings. And we continuously work on education for our staff on infection control, which includes not only using that PPE, but also when we go into the person's home and what's called bag technique and hand washing and hand hygiene. we're continuously working on educating our staff for infection control. And also, throughout that time during COVID, especially nursing visits, we were still providing those in-person visits. And even today, we've taken some of these techniques and we have moved into this new norm, and we're still, as I said, offering the telehealth, utilizing PPE, performing testing as needed, focusing on infection control. And now about 99% of all of our visits are done in person. So also, once again, pivoting. So we have our treatment services for our nursing and our therapy. And we had all of this educational content where we were providing those live clinical presentations for nurses, case managers, direct care staff. And that was not available anymore, of course, because of COVID, to provide those presentations in a group setting. So just like we are here today, we as a company set up live webinars with our own Zoom account and promoted those with our various providers, and also through Department of Developmental Services, companies like Nonotuck, and also the Mass Rehab Commission. So we were offering these live webinars starting back in June of 2020. So we could not only keep getting that educational content out there, but we were also, for nurses, able to provide CEs in CEUs. And those live webinars, we continued to have the same topics of the dysphagia and aspiration prevention, the fall prevention, the skin breakdown prevention, and the safe individual and patient handling. When we moved into the year 2021, we pivoted again with VRNS EDU because lives continued to get crazier and busier. And we took feedback from our live webinars. And one of the biggest pieces of feedback that we received is that instead of having live webinars all the time, it was best to put those on demand. And that's what we did. So we now, from an educational standpoint, provide on-demand educational series. So those topics of dysphagia and aspiration prevention, fall prevention, safe individual handling, skin breakdown prevention, we broke those down. Instead of one live webinar, we have numerous throughout the month on-demand 20-minute webinars. So you can take that information, we break it down, so maybe you don't have an hour, but hopefully you have 20 minutes to take and review that content, and you can do it at whatever time that you want. You can do it at 8 in the morning, 10 at night, because it's on demand. And also, those being on demand, not only are those webinars available for anybody, clinical staff, we were hoping to get more direct care staff and more individuals to view those webinars. Some of you may be on our email list and get information on those webinars. And if you're not on our email list, please contact us and you'll have that information. As we do have a quick question here, I see, are the webinars open to the general public? And yes, they are. You will need an access code, which is provided to you. This month, right now, as we speak in May, we are doing, the topic is on dysphagia and aspiration prevention. At the end, my email address will be there, so you can contact me directly and I can get you the information to those webinars. And each month, you're welcome, Donna. Each month, we will be issuing a different topic. And next month, somewhat breaking news, but we're going to do skin breakdown and prevention. All right. So get on our email list so you can get some information. And we do release a couple a week. So once again, you don't always get all of them. But because of we do re-release throughout the month, different months. As an example, we started February was fall prevention. March was dysphagia and aspiration prevention. And then because of the popularity and because people wanted the content again, we re-released fall prevention in April, and we're re-releasing dysphagia and aspiration prevention this month. And one more thing, before I forget, and even we have received many inquiries too from even AFC providers as to working with them about how can we get this information to direct care staff. We've had case managers reach out to us, and we can work with you guys on how do we get this content to the direct care givers. Also, part of our VRNS EDU and part of the pivot and part of our vision of providing optimal functioning, prevention of declines, prevention of hospitalizations, we also started to create some programming where we can work with various providers about putting different screenings and interventions in place. And we started with fall prevention because we know how much of a factor in our individuals' lives falls and fall prevention and the effects of falls are. So what we did is we worked with a couple of different community-based providers, and we took evidence-based tools from what are used for the senior population, and we put this together. And we work with providers with how can they implement this tool? How can they look at a fall risk screening tool so we can look to get interventions in place before somebody falls? And part of putting this together was many providers do have a fall risk screening tool in place, but what we found is it was not comprehensive. It was very generic. And usually it was just, well, we looked at something online and it didn't really meet the needs of our patient or individual population. And it also put everybody at high risk for falls. And, because everybody was at high risk, we didn't, or the provider didn't really have great interventions in place. And there's one other piece that we found too, is providers were screening the individuals. Maybe not, it wasn't the best screen, but they were not putting interventions in place. So part of the programming that we work with providers and put into place was not only do you have this screening tool, but we have potential interventions or going through a checklist or a laundry list of, okay, maybe somebody has vision issues. and they have low vision or have cataracts. So let's think about, we don't necessarily have to be involved or a skilled provider, but have we put a tactile or touch guide on the walls? Have we highlighted the stairs as we know depth perception? If you have the same color and an individual or patient has depth perception issues, you need to add contrast, or else they don't know that they can't differentiate between the step. How many individuals or patients have a 1970s bathroom where everything is the same color? The toilet, the wall, the bathtub, it's maybe all brown or pink. If they have vision issues and they go to step over the tub, an individual can't differentiate between the height of the wall, or the tub wall, and the depth of the wall. That's one example of you have to screen the individuals or patients ongoing because we want to capture change, but we need to put in interventions in place to provide some generic strategies to prevent a decline or a fall. And that's what we do and help with the providers with our fall risk screen. So at the moment, what I would like to do is just take a few-minute break so people can stretch and go to the bathroom if they need, get a drink. It's 1:42 at the moment. I will come back at 1:45. And what we are going to talk about now is the top 5 ways that we as a company and our services promoting optimal functioning help your individuals. So if you want to take a moment, and I will come back at 1:45. And certainly during that time, please, any questions so far on the information, please throw it in the chat, and we'll start with that at 1:45. All right, we will get started again. Hope everybody was able to take a little stretch, little break, get a little drink, and we will continue on. So when we're talking about these top 5 ways our company can help promote optimal functioning, I really want you to think about whether it's your family member, your patient, individual, client, whatever word that you utilize in your setting. And one that these resources and services to promote optimal functioning for individuals in the community are available. Our services are out there, and we are unique from other home healthcare companies. And with our mindset and our treatment focus of really working with those community-based individuals. Okay. So these 5 ways we promote optimal functioning are the top 5 reasons for referrals, why case managers, doctors, family members refer patients and individuals directly to us. So we're going to talk about how we help somebody when they're discharged from a skilled nursing facility or a hospital, somebody that's an aspiration risk, somebody that is skin breakdown risk, how we help people get medical equipment, and somebody that is a fall risk. And as you can see, and it's not a coincidence that these top 5 reasons for referrals are also what we provide education on from a content standpoint with VRNS EDU through our live webinars and our on-demand clinical series. So first, when somebody is discharged from a skilled nursing facility in a hospital, and I put this on here because not only do we work with individuals from the community, but we do also work with many individuals that after they are or when they're discharged from a skilled nursing facility or a hospital. And there's a few key pieces here. One is when somebody is discharged from a SNF or a hospital, we always have to keep this in mind. Has this individual had a medical or functional change? Many times, even I have gone to work with individuals or patients, and because the caregiver does not understand the clinical or medical piece, which they're not supposed to, they unfortunately still see this person as the same person prior to that discharge. So they think that person still might be able to walk like they once used to, or they might be able to just get up and go to the bathroom and be able to toilet themselves like they used to. Or cognitively, you can still have a conversation with them. But sometimes they have changed. Hopefully they'll get back to their prior level. But we have to keep in mind, has an individual changed both medically and functionally when they return home? Where we help and come in to play is, once again, kind of that prevention, environment, modification, is we want to be part of the discharge planning process. We want to be part of those transition or discharge planning meetings. We want to help identify as a team member, what are those needs prior to discharge? So is it from an educational standpoint that we can help start educating before the discharge? Can we start help to get equipment before the discharge? Can we look at environmental modifications, or is that doorway wide enough before the discharge? So we do that before the discharge. And then when somebody comes home, right away, we do evaluation and education on the person's medical and functional abilities. So the caregivers, whether it be the caregivers, the staff, the family members, know how to properly care for this person. We also look at how can we adapt the home environment? How can we work with you to make recommendations on maybe they're in a wheelchair now, and how do we get that wheelchair through the doorway? Maybe they're in a walker, and the bathroom, you can't just walk to the bathroom through the walker, or maybe it's the grab bar next to the toilet. We look at those home environmental modifications and help get that equipment. And then skilled services, we provide that nursing, PT, OT, and speech. And what we provide is very unique to the individual. Their plan of care is very unique, depending on their needs, their medical condition, and their diagnoses. So from a skilled nursing standpoint, it might be assessing their heart and lungs because they had COPD or a pneumonia. Or they might have had increased, they might have hypertension or increased blood pressure, and we're monitoring how the therapeutic effectiveness of the medication. Are their blood pressure now in normal range? And can we educate the family member or the caregiver on how to take those blood pressure? Or maybe they have CHF. They have to monitor the weight. Maybe they're just on different medications, and we're looking once again at the effectiveness of those medications. And a big piece with nursing is to get that person medically stable, working with the doctor, because we are like the mini hospital at home, working with the PCP or whoever the doctor is giving orders to make med changes. So maybe that medication isn't working, and we provide those readings to the doctor, and the doctor says, all right, we now need to increase it, or maybe even decrease it because their blood pressure is low. Some examples, very unique, depending on the medical conditions. And then PT, from a therapy standpoint, we're always, we're doing that education and evaluating and determining the current level of function, and then getting them to their optimal level. So normally when somebody's been discharged, they've had some type of decline. So PT, and I see a couple of questions that I will get to. So PT, they evaluate the legs, the gait, the balance, and how can we get them as best to their functioning ability for walking. OT typically looks at activities of daily living. So how does somebody get bathing, grooming, dressing, toileting? And don't forget what we call IADLs, which are meal prep, items like that. And once again, we evaluate, look at what are the limitations to get somebody to their optimal level. And then also speech therapy. They do a ton of work with identifying what the safest diet is. Can somebody swallow safely? Upgrading the diet. And they also look at cognition. For individuals with dementia, or they might have had some type of injury that causes cognitive issues. And then we also, or speech therapists also look at speech. So One of the questions is, as an AFC provider agency to persons funded primarily by Medicaid, would these areas all be able to be covered, including the discharge planning, education of caregiver? So anything when a person is not in the community yet, so maybe they were in the community or they're currently in a skilled nursing facility or a hospital, those services aren't directly covered, but it's part of the services that we provide if we're going to work with the person so we can best meet their needs. It's part of the customer service that we provide. When somebody is discharged out of the facility, whether it be a skilled nursing facility or a hospital, that's when, from a coverage standpoint, the services are covered. Now, as I mentioned from at the beginning, these services, these skilled services, the nursing, the PT, the OT, and the speech therapy, are covered by Medicare, Mass Health, and many other payer sources that we're involved with, like some of the managed Medicare benefits and the Tufts Healthcare of the world. There's so many of them, we can't mention all of them. And I know most of the primary funder for AFC is Medicaid or Mass Health. One thing to remember is typically for skilled services, Medicaid or Mass Health is the last payer of resort. So if somebody has Medicare, that would be primary. They don't have Medicare, then you go to the Mass Health or the other payer source. But all of those services, as long as they meet the needs of a doctor ordering the service, and they have been seen by a doctor, which they would have been in the skilled nursing facility or the hospital, they can be seen in the home setting. And those services are covered in the home setting by the Medicare or Mass Health. And the frequency and duration of those services, whether it be skilled nursing, PT, OT, and speech, are individualized to the patient or individual need. And sometimes there is depending on the benefit, somebody might have a benefit of 20 visits or 12 visits, then you have to get approval. But if you have Medicare, there's no specific amount of visits or coverage area. And the other question, with all insurance covering the services like attending a discharge, once again, those are not covered, but part of our services is we will be part of that discharge planning. So that's why like Trish Phillips, who is on this presentation today, this webinar today, that's one of her roles. She participates in those discharge planning meetings. We have other staff members that work with Trish that are part of those discharge planning meetings. So next, our number two. I'm sorry, just going back to a question. What said the need for a 90-day stay in the skilled nursing? So the 90-day stay in a skilled nursing facility, that had to do or has to do with individuals under the ABI and MFP waiver program. So that's a very unique program that under that program, products and services not covered by insurance like Medicare and Mass Health are covered by the waiver program. But anybody that's discharged from a SNF, a skilled nursing facility, or a hospital under the traditional non-waiver through their Medicare, their Mass Health, there is no specific amount of stay that they have to have been in a skilled nursing facility or a hospital. The only reason or the justification for services under insurance is you need a doctor that will write orders, both provide an order that says, yes, skilled nursing, PT or OT or speech therapy is medically necessary. And then they had to have been seen by that doctor or a doctor, an MD, could be a neurologist, could be a cardiologist, could be a hospitalist, that during that visit for the doctor, there's just a medical justification for that nursing PT or OT. So a lot of those, somebody being discharged from the skilled nursing facility, because they're medically acute and have had changes, they would have been seen by a doctor that would meet that what's called the face-to-face visit, and then either the doctor from the skilled nursing facility or the doctor from the in the community would provide orders. So next we have somebody, and you're welcome. And next we have somebody that is an aspiration risk. So we have and this is many people in the community, if they're not at risk for aspiration now, they could be in the future. So we have our OT and speech therapy. We have OTs are also trained in this. We have some OTs. They evaluate, determine, and educate an individual and the caregivers on the safest diet. So we look at these phases of swallowing, and we say, based on that evaluation of the phases of swallowing, can an individual tolerate a regular consistency, a chopped consistency, a puree consistency? And we make that recommendation. That recommendation goes to the doctor and they officially sign off on it. And do note, if just because somebody goes from like a regular consistency to a puree, we can help them get back to that level. A lot of times they'll go into a hospital or quickly, and they might have downgraded their diet. And before they are discharged, they don't even have an opportunity to potentially upgrade their diet. Speech therapy and OT will also recommend and educate individual caregivers on feeding techniques. So once again, somebody in the community, I've worked with many individuals myself because of being even in an institution. They don't have a swallowing problem, but because of their feeding technique, it puts them at risk for aspiration. And so we can provide techniques to help them swallow safely. We also can recommend an MBS. An MBS is a modified barium swallow. And pictured here is actually what an MBS is. If you do not know what it is essentially it's an internal X-ray. You put barium in the food, so then you can actually see the food go down, hopefully the esophagus, and into the stomach. Okay. So these are actually pictures from MBSs, modified barium swallows, where A is actually a normal swallow. You actually see the chin here. This is the spinal column, the esophagus. Okay. And this is actually food that can get stuck in the back of the throat. This is when you go to swallow food that can go into the airway. This what's called penetration into the airway. This is the trachea, or the tube that connects your lung to your lungs. And then you hear full aspiration into the trachea and the lungs. And aspiration, what aspiration is when that food gets into these lungs. And in that food is bacteria. And that bacteria gets into our lungs and causes a pneumonia. That's what happens with aspiration, and that's why they call it aspiration pneumonia. And so it's very important that we look at these strategies and we evaluate to prevent that food from getting into their lungs, thus causing an infection or a pneumonia. You and I, or people that have immune systems, this happens all the time where you might be drinking and goes down the wrong tube, you cough, you might be able to cough that up, get that food or that liquid out. It might go into your lungs, but you have the immune system to fight off that infection. Many of our individuals do not. Also, to create or minimize the risk of aspiration, our OTs help to identify and implement adaptive feeding equipment. Because statistically, somebody that can feed themselves, even with adaptive equipment, is at much less risk of aspirating than if you, I, or any caregiver needs to physically assist somebody with feeding. And just as a side note, and we go through this in our aspiration prevention as a strategy, but it's a common one that I see, is if you have to feed a individual, please think about two things. One, feed them at a eye level. So don't stand over them and feed them like this, promotes that cervical or neck extension, puts them at risk for aspirating. And also think about either visual issues or if they've had like a stroke or neurological issues. And we always want to feed the person on the side that's not affected. So if they have visual issues in this eye, we want to bring the food on this side, not on this side, because if you bring in this side, you cross the plane and all of a sudden they can't see the food till it's right in front of them. But our OTs help get this feeding equipment. They recommend feeding equipment, unfortunately, is not covered by insurance, whether it be Medicare or Mass Health. It's usually not that expensive, but can help quality of life, especially for those individuals that the only control they have over is their feeding. That you, on the top left here, you don't even need a grasp. You can even use a cuff to feed, or for an individual to feed themselves. The other piece about aspiration risk, and a lot of times is forgotten about for individuals in the community, is positioning. If somebody's on a modified diet, our OTs and PTs evaluate for proper positioning. So if somebody's laying in bed and they are on a modified diet, meaning they're not on whole or cut up or chopped, they're on a puree or ground, and the doctor says they're on aspiration precautions, their head always has to be elevated at 30 degrees. So like this person, their head is elevated at 30 degrees. You can only do that two ways. You can only do that through to get a wedge in a regular bed or through a hospital bed. And picture down at the bottom here, we even help mark beds so we can identify exactly a hospital bed that is at 30 degrees. The next area that the common referral is about skin, somebody that is a skin breakdown risk. This is really, like many, a true interdisciplinary approach between nursing and our therapy services. And our skilled nurses evaluate the affected area and they recommend and provide treatment. So hopefully that wound has not opened up or that area has not opened up. But if necessary, they'll evaluate that area that might be prone to the wound or opening up. And then if it is actually opened, they will work with the doctor, whether it be the PCP, get them into a wound clinic or work directly with the wound clinic to make recommendations and actually apply the treatment. And when I say apply the treatment, either that be a cream or a dressing, so they can clear up that wound. And I put this on here too, for any of you out there that work with family members, patients, individuals, that people are most likely going to get skin breakdown on what we call bony prominences. Anywhere on our body when there is pressure and there is very little adipose or fat between the skin and a bone. So sitting, heels, toes, back of the head, our scapulars, our coccyx, which we all think about, but sometimes we forget about laying down, in ear, the side of the hip, the knee, the ankle, laying down on your back, the knee, the ankle, the toes, the coccyx, the elbows, the back of our head. And our OTs and PTs recommend post-discharge maintenance programs. So if somebody isn't able to ambulate or walk on their own, we can work and educate on a walking program. Our OTs and PTs, to prevent skin breakdown, they recommend educate on proper positioning. So do we have any individuals, clients, or patients that slouch over to their wheelchair or slide forward into their wheelchair? That's a very common way that we help. We look at that positioning. We try and make modifications to their current chair, or we recommend and implement the proper DME. So we might, and we're going to get into the DME. So I'm going to talk about that a little more. But that's something, because the whole goal with positioning, thought we might have a question there, we got to get somebody positioned properly and get the correct DME in place. So moving right on to that, another common referral for us is to help somebody get medical equipment or durable medical equipment. Our PTs, our OTs evaluate, implement, and help obtain that equipment, and then also educate on the use of the equipment. Not just say, all right, you need this, and whenever you get it, good luck. We also come back and help educate on that equipment. And we educate and we help with standard and custom durable medical equipment. And when we talk about standard equipment, we help get walkers, wheelchairs, tub transfer benches or shower chairs, hospital beds. Okay. So if somebody needs a piece of medical equipment, it's somewhat of a pet peeve of mine, not just because I'm an OT, but I see it all the time, the wrong equipment the individual has. That please, if somebody needs a piece of equipment, don't just call the doctor and have the doctor take care of it. Try and have an OT or PT evaluate. Because there's some small, simple details that can make the world of difference to get the correct equipment, and also to educate on the use of the equipment. Many times I've seen a doctor will order just a walker because there's a gait issue, and the person that they get the walker home and it can't fit through a doorway, and it puts them more at risk for falling, or they didn't get a tray and now they're walking around with the walker with one hand and a cup in the other hand because they're going to get a snack, or even they have to do meal prep. Okay. Or even knowing what's covered, what's not covered, and assisting in getting that documentation. And even working with the families, because how it works these days, if you get a walker through insurance, the individual patient is now not eligible for a standard wheelchair like this for 5 years. Does not matter if they've had a change, if they can't use the walker anymore. But so you have to use clinical judgment to say, all right, this person, maybe they have a condition like Parkinson's, and we know, unfortunately, there's going to be a decline in 5 years. That says, maybe, you know what? Maybe if they need a walker, if you have the funds, buy the walker right now, so then you can get a wheelchair in maybe 2 years. And then even helping getting hospital bed. Hospital beds are absolutely very, very challenging to get. But, and a lot of family members, case managers, they don't know that hospital beds has nothing to do with how the person functions. All it has to do to qualify is positioning. If somebody needs the head of the bed elevated, whether that be for dysphagia, aspiration, or a cardiopulmonary diagnosis like COPD and CHF. But we do a ton of help with just these basic pieces of equipment. And then also custom equipment, because this involves a different type of vendor, which we coordinate. It involves writing up a letter of medical necessity, which our PTs and OTs do. And it requires a thorough assessment to make sure we get the right piece of equipment. So we help get these tilt and space wheelchairs. We help get these power chairs. And then even if somebody in the home setting has a roll-in shower and it fits, and they're in a wheelchair like this, we can help them get a custom shower chair so they can take a shower safely. So if they can't tolerate sitting a standard tub transfer bench like this, and they have a tilt and space wheelchair, a roll-in shower, we can help them get a custom shower chair like this. All these pieces of equipment, as long as they meet the needs, both the standard and the custom, are covered by insurance. And then we get to the fall risk. And this is a huge piece, as we talked about. We help our individuals. We do the assessments for the tug. We work with providers and say, you know what? Because based on the evidence, if somebody scores greater than 12 seconds and the tug is, it's so simple, as I said, that we educate our providers and even family members to do, that all you have to do is somebody that's ambulatory, you have them stand up, walk 10 feet, turn around and sit, and you time them. And technically the evidence says that if a senior cannot do that within 12 seconds, they're at moderate risk for falling. Typically anything greater than 20 seconds, it's at high risk for falling. So even after this, sometime today, I want you to get up and time yourself. Get up, walk 10 feet, turn around and sit. See how long it takes you, okay? But for us, what we do is we provide clinical guidance, strategies, recommendations for somebody before they fall, okay? We can help somebody out after they've fallen, but we want to help prevent that fall also. We want to be a piece of that puzzle that helps prevent that fall. So our skilled nurse, PT, OT, they evaluate and implement strategies in the areas that place an individual at risk for falls. And yes, nursing is involved with decreasing falls because we look at medical changes. So we take that fall risk screening tool that we use in clinical programming and help providers, and we implement that. We have our staff utilize this also for fall risk if that's what we're referred for. We look at, has somebody had a previous fall? If somebody's fallen before, odds are they're going to fall again. Have they been hospitalized? Have they had medical changes? Elimination, bowel, bladder. Is there an increased urgency? Gait mobility, the most common reason for referral for fall risk. Do you have somebody that's shuffling, that can't pick up their feet? Even with a walker, they're hunched over, they're shuffling. Is their balance off? We assess those areas and make recommendations. Orthostatic changes, once again, where our nurse comes into play. Do you have somebody that gets dizzy going from laying down to sitting up? Change in position. And then cognitive and behavior. We look at these areas. Is somebody impulsive? Is there sundowning? We look at the environment. A huge piece of preventing falls is the environment. Can we put adaptive equipment in place? Can we recommend the correct footwear? We evaluate all those areas. We make recommendations. We help you get that equipment, help you put those strategies in place. So with all of these services that we provide, I want you to think about, and hopefully with a unique home healthcare provider like us, but that vision, all of the vision for all of us that are caring for individuals in the community is, how can we create optimal functioning for them? Because that optimal functioning means prevention of falls. It means prevention of declining. It means prevention of hospitalizations. It means increased quality of life. And for us, we want to be a part of that puzzle of providing that nursing, PT, OT, and speech therapy to help you, your family members, and your individuals get to that optimal level. So for us in particular, if you have any interest in any of our services, education, anything like that, for skilled nursing, PT, OT, and speech, you can always shoot me an email. gstelmack@vrnshh.com, or you can go right on our website, vrnshh.com/make-a-referral. And what we do is, for any of our providers, we ask them that you just get us the referral information, and we will take care of contacting the doctor, getting the order, getting all that face-to-face information. We will take care of getting all that. Once we have that, we can schedule the eval, all those sort of things, but we take care of getting that, okay? We don't have our families calling the doctor, getting that. We take care of that. And then for our educational items, whether it be for your staff, for yourself, for your individuals, for your patients, information, go to vrnshh.com and click on VRNS EDU. You can also email me directly to get on our mailing list, so you'll always be getting the up-to-date, on-demand educational webinars when they're released, and any information about the educational pieces. So, once again, I just want to say thank you for the summit, to allow us to present our services for those that we currently work with out there, that we have relationships with, for providing our services already, for those that we help educate, families and staff members. I just want to say thank you for the opportunity. We never take it for granted, the opportunity to provide our services. We are not perfect, but I think we do things pretty well. As a company, as I said, myself and one other person, we started back in 2008 with just him and I, doing everything from processing referrals to providing treatments. I am very much still involved in the everyday operations of the business and providing this education because it's what I love to do. But even now, we service, we won't even get into the numbers, but we have over 100, I think today, 124 PTs, OTs, and speech providing services in the community because of our unique model and because of, I think, what we've done for a great job. And we provide these services geographically. We have individuals and patients in the Springfield area. We go moving, I know usually we go east to west in the state, but west all along the Mass Pike, all along the Worcester area. We Metro West area, just north of Boston. We're not quite up in the Northeast area at the moment. But then the South Shore, anything south of Boston, South Shore, Cape, not the islands, but the Cape, we provide those services all throughout that part of the state. I even put my cell phone number up here. If you have any questions, call me, send me a text to set up a call, email me. Please do not be a stranger. And all in all, we have just a few minutes left. So I think that was perfect timing. Please, in the chat, if anybody has any questions, please put them in the chat right now, and I would be more than happy. After the slides go out, my email will be there. So please, any questions, reach out to me so I can help get those answered for you.
Thank you, Greg. We'll leave the chat open for the next couple of minutes for folks to get any questions to you. In addition to the recording of this webinar, which will be up on our AFC Summit webpage in the next few weeks, we will be sharing all of Greg's slides via email along with his contact information for folks to connect with him, ask any questions, or certainly talk about referrals. We'd like to again thank both Greg and Patricia for joining us today for the 5th annual AFC Summit webinar series. We hope to have Greg and VRNS back as part of our roundtable series coming back in July. We'd also like to thank today's sponsor, HMEA, and we hope to see many of you back for tomorrow morning's webinar, Skills Capital, How Investing Time and Hard Work Now Will Lead to Dignity and Fulfilled Lives When We're Gone, presented by Cheryl Chan, parent, advocate, and person-centered planner. Thank you so much, Greg, Patricia. Thanks everybody for joining again today.
Thank you, everybody. Everybody be safe and well and enjoy the nice weather.